and welcome to the week. This particular episode, a very special episode of the week's podcast, is about conversations that matter. It is about turning cutting edge medical research into real life conversations that matter. We are speaking about the potential of semaglutide, the drug that has changed the way we tackle, the way we look at weight loss, the way we look at stress, we look at various issues and how beautifully they can be tackled, which was never like this before. And for that, to explain to us the very potential of semaglutide, we have someone who's very capable, able, and who is the chairman of Zandra Healthcare. Please welcome our guest today, Dr. Rajiv Kovil.
Thank you so much.
Welcome, sir, to
Thank
this
you,
special
Pooja.
episode. Right. So we have seen how Prime Minister Narendra Modi has recently spoken about, how obesity has become a public health emergency in India and what all we should do to tackle it. So first of all, tell our viewers, why is obesity such a big issue? What makes it an issue in the first place?
So, thank you for the question. And obesity, first, we need to first classify it as a disorder because it's the mother of multiple other disorders.
Right.
There are more than 240 disorders arising out of obesity. And we are trying to treat those disorders and not actually addressing the core problem, which is obesity. At least 14 types of cancers are driven by obesity. And if we don't treat obesity, we are just going to treat the byproducts of obesity, which could be diabetes, blood pressure, cholesterol, obstructive sleep apnea, osteoarthritis. All these are byproducts of obesity. So we need to treat the core problem, and we need to understand that obesity per se is a medical condition. It's a chronic relapsing condition. So you may treat it, but it will again relapse. So we need to first understand that it's a medical condition which needs to be handled by medical experts, very much similar like blood pressure problems or diabetes or asthma or any of these problems, which needs to be actually assessed by experts and treated by experts. So first and foremost, we need to understand that we need to treat obesity as a medical disorder, and weight seems to be the driver of multiple other comorbidities. So obesity is a cluster of many metabolic abnormalities in the body. So in some you may have obesity causing heart disease, in some it may be causing heart failure, in some it may be causing diabetes, some it may be causing fatty liver, in young girls it may be causing infertility or polycystic ovarian syndrome, in some people it causes sleep apnea. So in what way obesity causes a problem in one individual can vary. It could be a hormonal problem, it could be a metabolic problem like diabetes, or it could be a mechanical problem like osteoarthritis and sleep apnea. But first, we need to make sure we are able to recognize obesity as a disorder. And Prime Minister Modi has done a fantastic thing, has taken that effort. And I think if we can reduce the weight of the nation and make India shrink in terms of the weight, I think we can change a lot of outcomes for India.
Right, I'm sure. And also, I think there is this special, connection of obesity with type 2 diabetes. Many of us here in India, especially now, the numbers are increasing. So many of us are living with type 2 diabetes. Some of them are aware, and some even remain unaware, which is very sad. So please tell us how are these two connected?
Very good question again. That till now we always thought that type 2 diabetes is a chicken and egg story of which came first, whether it was your lack of insulin or the insulin not working. But today we know that there are many hormones and glands which work in controlling the glucose in a very tight and narrow range. But what we don't understand is that obesity per se and diabetes are two sides of the same coin. And in obesity and diabetes, you have deposition of fat in organs where they should not have been deposited. So ideally, fat is to be deposited under your skin in the subcutaneous tissue. That's a natural depot for fat. But if fat gets deposited in the liver, you get fatty liver. If fat gets deposited in the kidney, you get fatty kidney. Similarly, fat gets deposited around your arteries or inside your arteries choke. Fat gets deposited in the pancreas, the functional capacity of the pancreas goes down and you get diabetes. So diabetes and obesity is wrong deposition of fat in the organs, which is influenced by genetics, environmental factors, and also the food we eat and the nutrition and the exercise we do. So there's a lot of interplay between hormones which act on diabetes and obesity, and they are almost the two sides of the same coin. That's why there's a lot of correlation, and most people with diabetes and obesity would have the underlying pathological condition called insulin resistance. And insulin resistance is the metabolic environment inside. It's not like we don't have to keep doing blood tests to actually find out what is insulin resistance. It is the metabolic environment inside which converts whatever we eat, whether we eat roti or fat, it gets deposited into fat in our organs. And that organs where there's more deposition of fat, the function of that organ goes down, and you may get fatty liver, you may get fatty kidney, you may get heart disease, you may get diabetes. So in which form obesity may actually put up a disorder or a disease on you, you don't know. So you may have a person with obesity with fatty liver, somebody with obesity with diabetes, but the origin seems to be the same. There's this common soil hypothesis. How it manifests in a particular individual can be very different.
Yeah, right. So, so here the problem is, and the solution is weight loss, basically. And how for we've all seen. I don't think anybody is unaware about this. How difficult and challenging it gets to lose weight is anybody's guess. So, what really how and many people think that consuming drugs for weight loss is not a good idea. Can you please bust this myth? What do you think about it?
So first and foremost, there's this willpower delusion in everyone's mind that obesity is about lack of willpower. It's about lack of character. One eats because he cannot control his urges. But one needs to understand that the urge to eat, craving, and satiety are controlled by a very complex hormonal environment. So you have hormones in the brain which increase your hunger, which is called ghrelin, which are the hunger hormones, and you also have leptin, which reduces your hunger. And then there's a hormone called GLP, which works from your abdomen and has an axis on the brain and abdomen, and it has access on multiple other endocrine hormones. But importantly, when one starts eating lesser, and when one starts under eating to lose weight, the brain realizes this. Because the brain is this kingpin in this blunder of diabetes or obesity. That is the big boss. So the brain realizes that, oh, she's eating lesser, so it increases the hunger hormones and it reduces your metabolic rate. So when you eat lesser, you become sluggish, you sleep a little bit more, and you will say कि वो कुछ खाया नहीं तो फिर मुझे आज ताकत नहीं है. And then after 4 weeks of dieting, your weighing scale has not moved. Then you're very disappointed. At the same time, the brain realizes you're not eating, and it increases your hunger hormones, and you start overeating. So this, most importantly, people need to understand the brain is making you crave and eat wrong, and you get cues for eating from everywhere around. You open social media, you have a burger, you have an omelette coming up. You go to a particular place, and you know that that place has the best bhel puri in town or the best vada pav in town. Here the smoothies are good, here the juices are good. So the brain keeps getting these cues, it assimilates, and it makes you crave for that kind of food. So it's not that there's any willpower here. It's basically a chemical locha in the brain. So the brain is doing this. So we need newer technology and newer drugs which can actually trick the brain, and that is how semaglutide comes into the picture. And first and foremost, the person with obesity needs to understand that it's not guilt. He should not feel guilty that he's going to use an anti-obesity drug. Obesity is driven by hormones, and this drug works by biology. Okay, the diet that we do, or the fat diet that we do, that works against the biology, and that's why the brain tries to increase the hunger hormones. So what these drugs do is that it, one, tricks the brain and does not let it feel. It maps the hunger and satiety centers of the brain. Okay, so the brain does not understand that you're eating lesser. So the brain does not reduce your metabolic rate. Your metabolic rate remains the same. So with these drugs, you tend to eat what your metabolic need is. You don't tend to overeat. So you may just go to a buffet, and one person who's he will enjoy the food, but he's only taking that portion for it. He will not increase his portions, because many times people need to eat enough in their stomach to stop eating. You know, here you will eat according to your metabolic need. It also reduces the movement of the stomach. So when the movement of the stomach reduces, you are not able to eat very fast. You eat very, very slowly. Your digestion is good. So automatically the signals go up to the brain, the leptin, which is the hormone which gives you fullness and gives you that fullness. So these drugs work in both these mechanisms, and it is the most natural way, because you sometimes lack these hormones or lack the actions of these hormones. That is why I say that these anti-obesity drugs like semaglutide works on the biology of the body. It is not something artificial. On the contrary, when you're feeding yourself for a fad diet, or a lot of people say that I will not use a drug, actually you're trying to fight the body. You're going to fight against the biology of the body. So these drugs actually work on the biology. One should not feel the guilt of using an anti-obesity drug. On the contrary, one should feel grateful that medical science and technology has evolved so much that today we understand so much about this. Till now we thought that, oh, this man is having a sweet tooth, he's a foodie. It's not about food, it's not about being foodie. These are hormones in the brain which is making you crave and making you eat more. And these drugs work as per your biology, and that's why it helps.
So there is no side effect. There are no side effects of consuming the GLP-1 medicines like semaglutide.
So the side effect profile has been very well studied, and this particular drug is there in the world market since 2017. There's a lot of robustness of evidence. So there's not a drug which does has effect and may not have minor side effects. But there are no major side effects to these drugs.
No life-threatening side
Nothing.
effects.
And all these drugs have a fantastic pharmacovigilance world over. So everybody is viewing these drugs very, very closely, and they're very, very strong, robust evidence of semaglutide. And it's not just about losing weight and eating lesser. You know, people come down to a very lower hanging fruit कि वो आपका भूख कम कर देगा और आपका वजन कम हो जाए. It's not like that. It's not like, it has fought for all indications which are there for obesity related conditions. So whether it's diabetes, well, it helps in diabetes control. It also helps diabetes with kidney disease. So people with diabetic and kidney disease, there's a 24% reduction in outcomes. It also helps people with obesity with heart disease. It reduces almost 20% outcomes in people with obesity with heart disease. Same with heart disease with diabetes. Also, there's a good 18 to 20% drop. So it has a labeled indication everywhere. Again, it is seen in. It also helps people with NAFLD or MASLD and fatty liver. Biopsy driven studies which tell us that there is improvement, 50 to 60% improvement. So it is not just making a person look better. So if somebody says कि मुझे अच्छा लगना है photograph में, that is not the thing.
Right.
It's got medical benefit which
It's
is
more than cosmetic.
absolutely
Basically.
driven by actual science
Yeah.
and biology. That is
Yeah.
why it's got emergent risk reductions in the heart,
Right.
in the kidney, in the liver. And that is something that we should be proud about, that a drug which is treating diabetes and obesity has got benefits on the liver, kidney, heart failure, all these things. So in obesity with heart disease, it causes almost a 20% reduction in cardiovascular events. I'm talking a medical language, but today we know that anti-cholesterol drugs like statins, they are foundation of cardiology. They get close to 30-35% reduction in heart events in people who have already had a heart attack earlier. This drug comes close to 20-25%. So you can say that is as good as 60 to 70% of a statin. So it's got multiple benefits. So by using one particular drug, you are having ramifications on multiple metabolic disorders, and that's what we need. We need people to live longer without guilt, take care of their organs, and live peacefully. That's what this drug will do.
It's a very important takeaway message right there, that with one drug we are actually looking at so many different kind of diseases that can be treated. That brings me to my next question. So now when we talk about semaglutide, we have Rybelsus, which has been there for a long time, I think 4 years, and which is the oral form. Then we have the Wegovy, which is the injectable form. So how does a person choose, decide which one? Is it a one size fits all? Which clearly it is not. Every individual is different. Every body is different. So tell us, how would you advise?
So Rybelsus at the dosages that is available right now at the max dose being 14 milligram is only approved for type 2 diabetes. Okay.
Okay.
The higher dosages of 25 and 50 milligram have been now applied to the US FDA for an obesity indication. But right now it's only for type 2 diabetes. So it's for diabetes control, it's for controlling the weight in diabetes, also preventing heart disease in people with diabetes. So and some amount of reduction in kidney disorders in people with diabetes. Wegovy is the brand name for the anti-obesity drug. Same oral semaglutide in an injectable form is called as Wegovy in the anti-obesity segment and Ozempic in the anti-diabetes segment. So we have Wegovy which has been launched in India, and it has 5 different strengths. So 0.25, 0.5, 1, 1.7 and 2.4. So again, Wegovy has indications for obesity, for kidney disease, for treating liver disease, and further labeled indications are going to keep coming in. So you have to start at the lowest dose, and it's not that one size fits all, because some side effects are there. You have to see if the patient has any severe acid reflux problem, hiatus hernia, chronic constipation. There's a relative contraindication if people have had pancreatitis in the past. Absolute contraindication if suppose you have a family history of thyroid cancer, you should not be taking it. So once you have ruled all this out and the person fits the bill, which is based on his BMI and a staging on obesity, then we know that BMI of 27 with comorbidity or BMI of 30 without comorbidity, this person fits the bill to be taking injection Wegovy.
Okay, and but not someone who's obviously BMI below 25.
No, no. We have Indian cutoff which are below, but suppose the person has a lower BMI and has obesity related conditions like obstructive sleep apnea, for example, or severe MASLD, for example, then we will treat him with these drugs. But the drugs are started at a low dose, then they are slowly up titrated, mostly monthly. Sometimes we may do it once in 2 months also based on the response. And everybody has a sweet spot on what they actually would come down to. It depends on the dose that maps their brain. And so some people may get benefit on 0.5, some may get benefit on 1 milligram, some may have to go up to 1.7 and 2.4 milligram.
But does that depend on the BMI?
No, it completely depends upon what are the level of hormones in your body and what levels of GLP we will require to suppress your appetite and give you good sugar control. So it does not mean anything about, so a higher weight person requires
Requires
more,
more. It
not,
doesn't.
nothing like
Okay.
that. Absolutely nothing.
Okay, no, because that is the general
Yes.
perception that someone with a very high BMI will require a higher dose of the medication. It doesn't work like that. Right, right. But there is another, I think there is some doubt in people's mind that there is this rare condition, NAION. How do you pronounce it? I think
NAION, yeah, you are right.
Yeah. So it is said that that condition, is it aggravated by consumption of GL1 medications?
So NAION is a very rare condition, 0.1 in 10,000 years, 10,000 patient years. It is what was seen was in an observational study of more than 8 lakh patients. You had around 200 patients who had NAION. So it's a very small percentage and it's an observational data.
Okay. Is it very recent?
It's around a year and a half. And you have a very focused study on semaglutide on the retina, which is the study itself is called Focus, which will come out next year. And right now, these studies are having a lot of vigilance. So if there was even a small signals toward NAON, the study itself would have been terminated. So study is going on blinded means we have not found any signal toward NAON. It's a very, very rare occurrence in people with diabetes as such.
Okay, okay. So that can be ruled out as of now.
Absolutely.
And I think we can wait for the results to come next year, any which ways, right? So I think the takeaway message also is that we like semaglutide drugs like Wegovy and Rybelsus do not only are not considered to be effective only for weight loss or obesity or diabetes, but they help for a various variety of conditions. Um, so let's talk about, for example, if you could give us an example of who would be the right candidate for this. Maybe if you could help us with male, female, the age, and what kind of lifestyle will that person be having that makes the person vulnerable, or not vulnerable, I should say, makes the person fit the bill for Wegovy or Rybelsus. That would be great.
So first, let's first the assumption or the notion that obesity is a disorder.
Yeah.
So people who have high blood pressure, like 150 by 100, or somebody with asthma, for example, we don't tell that patient that if he's asthma that try to breathe better. We don't tell a person with 150 by 100 blood pressure कि आप थोड़ा तेल मत खाओ और salt मत खाओ and we'll see you later. Similarly, a person with obesity and its medical condition, we should not be telling them that it's a matter of willpower, try eating lesser and exercising and come back. There is a problem. Okay, so any person with obesity with 27 BMI with any other medical condition, whether it's diabetes, high cholesterol, high blood pressure, fatty liver, obstructive sleep apnea, osteoarthritis, then he fits the bill to be on the medication. Okay. Anybody with a BMI of more than 30 without any problem, okay, no heart failure, no heart disease, nothing, he still fits the bill because there's nothing like a metabolic healthy obesity. Obesity over a period of time will cause some metabolic issues. So if a person is above 30, he better take the drug and at least come down to a 25 BMI. And it's relapsing. Okay, so once you come down, doesn't a lot of people will ask, doctor, kab tak goli lena padega? So same for blood pressure, cholesterol, diabetes. We are supposed to take medications for long. It's not a short-term therapy.
Right. So that brings me to my question. Just sorry to interrupt, but if I am on a BMI of 30 and I come down to 25, I stop taking the medicine, or what happens?
Very good question, Pooja. The depends on why we started the drug. Now, suppose you get 7 to 10% weight loss. Okay, there's remission of diabetes. That means diabetes goes off. Right. Okay, if you have around 12 to 15% weight loss, then your MASLD, your liver goes back to normal. Okay, 15 to 18% weight loss, your lipid disorders go down to normal. 18 to 25% weight loss, your sleep apnea goes away. So it all depends on why have I started you for. I will not start you for looking good in a picture. I will start you for a medical disorder. And if I've been able to, I wouldn't use the word reverse, but remit that to the problem to normalcy, then I will consider stopping the drug and viewing you again. Because what data suggests is that after you stop the drug, over a period of 2 to 3 years, there can be a 20-25% weight regain. So if you have lost 20 kilos, you may gain back 3 to 5 kilos in the next 2 years.
That could be also because of complacency. If I stop exercising,
No, the body, the brain decides a particular set point for you, which is on multiple data and parameters. It could be based on your BMI, based on the activity do you do, based on your genetics. So initially you start losing weight and then you plateau, and
correct.
that's where the set point is. So we have to break that set point every time. So if you are able to break that set point, then you can go down very, very well. And again, I said it all depends on what we are using the molecule for. So if you have got the benefit, obviously you can, but majority of the time in your mind you should be that I'm treating the mother of all NCDs. So if I take care of this, most of the other problems won't come in, and usually we would tell that these are for long-term treatment. And even weight management, we say that it's chronic weight management. It's not acute weight management. I'm not going to give you 10 kilo weight loss in 2 months' time. It's a chronic weight management. And that's how the patient and the doctor and the healthcare provider should be on the same page, and there should be a very shared decision making in this.
So my last question, sir, before we close, as an obesity and diabetes specialist, you tell me from your own experience about some success stories that you have seen and that should be emulated, maybe even one or two, and how many patients who who fit the bill for these drugs? Do you see, maybe, or have you seen in the last 1 year?
So since the last 3 to 4 months that
Yeah,
we have semaglutide and the
yeah,
other drug
yeah. Sorry,
here,
last two, three,
we
4 months.
we have seen that that guilt which people had earlier is gone away. People are ready to accept drugs, and when we speak to them about what is the basic physiology which makes a person from normal weight to a overweight to an obese, then people accept it. Number one, success stories there are many. You know, from F3 fibrosis of the liver, which is the just a stage before cirrhosis,
Yeah.
to going down to F0. Okay, complete normalcy. People were not getting pregnant because of polycystic ovarian obesity and primary infertility, going down and getting pregnant. So these kind of success stories are overwhelming, and people who have not had kids, people who, and again, quality of life important also, which a lot of people come back after the 10-15% weight loss, their functioning capacity, like for people with heart failure with preserved ejection fraction, they were not able to walk for 20 steps, today they are able to climb. People who had osteoarthritis of the foot, they were not able to get up from a sitting position, today they are able to move around. People with obstructive sleep apnea who were we've had 3 patients like that who were dependent on CPAP, and with 18-20% weight loss they are off CPAP. So that is a huge benefit for people, and just the functioning capacity of the patient, of the person with obesity, should motivate the other, that look at my functioning today, I'm able to function 14-15 hours a day and still not feel tired about it. And I've the infertility, primary infertility, the remission of the liver problem, these are all a lot of success. And see, we've just started, we have just kick-started the semaglutide revolution,
Right.
and it only kick-starts. I'm not saying it's going to be a magic bullet for anything. It only kick-starts the person, because every person who tries to lose weight gets dejected, frustrated after 1 month, because there's no grams of weight loss. With this, you see something, then you're highly motivated, then all your happy hormones, your pleasure hormones, which earlier were linked to food, are today linked to getting better, getting healthier, and eating right. So there's a lot of perception change in people. The psychology of the person changes. He's much more fresher, optimistic. He's dealing with many things with more concentration. So there's a lot of change in people which comes in with
Right.
this.
And happier also.
Happier
I'm
also.
sure.
So my last take to people is that don't feel the guilt about anti-obesity medication. Just feel grateful that these drugs have come in at the right moment in time, with a lot of science telling us that this can change the whole obesity revolution occurring globally, I would say.
Right. Don't feel guilty about anti-obesity drugs. I think on that note, thank you so much
Thank
for
you so much.
talking to us, doctor. This has been immensely informative. And I think you have busted so many myths that most of us had about anti-obesity drugs, especially semaglutide and its variants. Thank you once again.
Thank you so much, Pooja. Thank you for having me here.